All right, we should be on and rolling. All right, so this is going to be our first comprehensive overview of the first examination. Remember, I'm not looking at the camera, so if it looks like I'm cross-eyed, it's because I'm reading something else on a different screen. So in the direct concepts that we learned, why don't you guys tell me a little bit about the different types of assessments that we have?
Focused assessment.
I like that for you. Tell me what a focus assessment is.
Just problem-based.
Ooh, I like how we said problem-based and focused. Okay, good. So tell me what that means to you. Like I can say a problem-based focused assessment, but I don't necessarily know what that means. So what is it? Give me an example of that. How about that?
Someone comes in saying that their ankle hurts, so you pretty much focus on that area. You probe and ask some questions about how that happened, how it make you feel, what makes it better.
Perfect. So what kind of assessment would you do in the line of assessments that we have options of? Would you do a cardiac assessment? Would you do an integumentary assessment? Would you do ortho assessment? What would that look like for you?
It would be more so ortho, because sounds like your bone is hurting.
Okay. What about integumentary since it's the above meat, above the bone and below the bone? Will we do that as well?
Yes.
Yes. All right, cool.
Yes.
Now, tell me what a follow-up appointment is going to be, or a follow-up assessment is going to be, or what they call it an episodic assessment. What is that going to be? What does it sound like? A follow-up assessment. You guys will do it all the time, 1 hour after doing this thing.
So after somebody had maybe a procedure or operation or something, they come in for a follow-up.
Dang, I like that. Only we're talking about acute care, so it's a little bit different, but that is a good example. Think more acute care. We could appropriate that with the patient because when the patient first gets to us, we're going to do a follow-up assessment on that patient regarding what? If they had surgery, we're going to make sure that they're not in
Pain.
Yes. This is what we call a follow-up assessment, right? I give a pain med, and then 1 hour later, I do a follow-up assessment. Make sense? Does it? Now, don't get this twisted with the focus assessment because technically that could be a focus assessment too. I don't want you to get too wrapped up into this, okay? This is just a very simple example of a follow-up, all right? So on the scale of 1 to 10 of things I need to be super concerned about, it's like a 2, all right? But I need for you to know what it means. Tell me what a comprehensive assessment is, and additionally, bonus question, what else is it called besides a comprehensive assessment?
Head to toe.
And then what exactly does that look like? Tell me the different body systems we go through for head to toe. Remember your acronym I gave you that was kind of bizarre? No respectable. You guys remember that one? Your acronym for neuro. Give me another one.
Integumentary.
I love it. What else?
Muscular.
Respiratory.
Respiratory.
GI. Cardiac.
Yeah. Yes. Now you're remembering. Cool. So no neuro, respectable, respiratory, cardiac, GI, GU, integumentary. Perfect. All right. Tell me what a screening is. Tell me what a screening is.
Are you asking in like health prevention aspect? Like
Yes, I am.
primary?
I like that very much. So what is a screening? What does that mean to you?
Maybe like looking or avoiding possible. I don't know how I want to word that. Sorry.
Keep going. Don't think about it. That's your problem. Quit thinking about it. You're doing good. Keep going.
kind of like an outline of preventative diseases.
Give me an example of screening.
Like, I feel like I should know so many screenings.
What makes sense in your brain? Because you're probably going to be right. When I think of screening, I think of blood pressure screenings at a church, right? That's a screening. I'm screening blood pressures at a church or at a CVS or whatever, right? I'm at the little booth in the front. And the whole purpose of this is what? Do blood pressures and be like, all right, holler. No, I'm literally checking their blood pressure to see if they run into a hypertensive area that they are not aware of. I simply let them know, hey, listen, I can't help but to notice that your blood pressure is a little bit elevated. You might want to go see a doctor about this. That is the screening tool. Is that going to help and give better outcomes holistically for an entire community? You betcha. So that is considered screening, which is what kind of prevention?
Primary.
Give me another example of primary prevention.
Would like a vision test be like a screening?
I love that. Give me another one. What's the most classic one that everyone knows?
Like a mammogram.
Wellness check.
Mammogram, is that primary? Remember what we talked about?
Secondary.
Eating balanced diet. Eating balanced diet.
Eating a balanced diet. That is primary prevention. Good. What about immunizations? The literally most classic textbook sign is immunizations for primary prevention. Absolutely. All those are really good. Do we have any other ones?
Exercise 3 times per week.
Yeah, I love that. Eating a balanced diet, exercising 3 times a week, making sure you do your immunizations, blood pressure screenings, things of that nature. All perfect. Okay. Now, when we collect data about a patient, all right, what do I do next to have a complete summation of all the problems I'm looking at with this patient? What do I need to do with this data? I have a little bit of data here. I've got imaging from over here. I got labs from over here. What do I need to do in order to have a entire approach and look at this patient?
Put it all together.
Thank you. Cluster the data. I know that sounds crazy, but we don't cluster data at all. We have a wave of information that is on Epic Charting. I can go back 15 years, sometimes 20, right? Depending on what kind of system I have or who I can cross the data with. We never use this kind of data. And this data is absolutely imperative to let us know about medication compliance, to let us know about, 30-day readmits, to let us know all kinds of data that is going to let me know what type of patient I'm dealing with. If I see a patient that's constantly non-compliant, am I going to give them a really high-risk medication?
No, absolutely not.
No.
No, why? Because I can't trust them. We never cluster the data. You absolutely have to cluster the data. Good job. All right, cool. Now, what's that? Oh, must have been a mistake. Okay. All right. So now let's talk about subjective versus objective data. Tell me what subjective data is.
Opinion.
Opinion, or what I like to call you're subject to be wrong, right? Why? It's not because the person's dumb. It's because sometimes they're just ignorant and they don't understand what that means, right? Medicine is a whole different ballgame. So someone's interpretation isn't necessarily going to be facts. So I'm going to play a game of subjective, objective. Fair enough? Incidentally, tell me what objective is so we can go ahead and knock that one out.
Fact-based.
Measurable.
Fact-based, or what I like to call, I have an object of objective data to let me know that this is factual, to let me know that this is tangible. Okay. So let's see. Dr. Molly weighs 158 pounds.
Objective.
Objective.
Who said objective? I'm telling you, I weigh 158 pounds. We all know that's a lie. Come on. That is subjective, and you're allowed to laugh. It's okay. All right. How about the patient is 5'8"?
Objective.
Objective. I did not say it came from a patient. Cool. How about +3 pitting edema on left lower leg?
Subjective.
Objective.
Objective. Love it. How about I've been having pain in my right toe.
Subjective.
Subjective.
Subjective, good. Current temperature is 101.6 degrees.
Objective.
Subjective.
Objective, I love that. All right, cool. You guys got that one down pat. And we are going to use it to our advantage. All right, so now let's play the game of secondary. Tell me about secondary prevention. What does that look like?
Like preventing something from going farther.
Aha, I like how you said farther. What does that imply?
Like when you have like a patient that has like, I don't know, high blood pressure and you try to help them not have it. Like
Dude, that's perfect. Because what you're trying to tell me is this is an action where we have an activity that is going to either teeter into one direction or teeter into the other. This is a matter of balance. I am pregnant and I have, gestational diabetes. As soon as I have that baby, my diabetes issue is done, right? But until that happens, I have to manage it and I have to make it better. Or if I continue to make it bad, it's going to get worse. And I'm going to tip the scales and then I'm going to end up in the tertiary zone. Okay. So now give me some examples of secondary prevention.
Post-stroke area with the walker.
I love that. Yeah. When I am post stroke, that means that my stroke has already done its damage that it's going to do. And I'm doing rehabilitation to get better and to potentiate retroactivation of those activities that I lost, AKA I was moving this arm. Now I'm not. Now I'm taking therapy so I can move it again as best as I can. What we need to do in this time is we need to teach them, because are they going to have another stroke? It's possible. And then we're going to tip into tertiary activity where this is a permanent problem. Right now, I'm already at the best baseline I can be. So technically, another stroke is either here nor there. It could happen. It could not happen. That's why I hang out in that secondary position. Now, tertiary. Tell me about tertiary.
It's when you have
it's
the
not
disease.
reversible.
It's not reversible. It's when you have what?
You have the disease and you're just trying to reduce the severity of that disease.
Oh my God, I love both of those answers. Yes, absolutely. So we have a position where we're stuck. I got COPD. I've got diabetes. I had gastric bypass and now I've lost my intrinsic factor and I have pernicious anemia. I'm not getting those back. However, what I'm trying to do is make it the best that I can make it in that moment to where it doesn't get any worse. So give me an example of what that looks like.
A diabetic on insulin.
A diabetic on insulin and helping them manage their diabetes. I love that for you. Tell me about something with asthma or COPD.
Inhaler.
Learning how to use an inhaler, the spacer appropriately to get the best breath. I love that for you. That's perfect. All right. What about cardiac rehabilitation? What does that look like? If I'm going to cardiac rehab because I had myocardial infarct and I had permanent damage, is that going to be a secondary or is that going to be a tertiary item?
Tertiary.
It's a tertiary, yep. Now remember, stroke, it could be a one and it's done, or it could be a permanent deal, all right? So if they don't tell us, we just have to assume that it's a one-time deal. Cool? You guys are going to do fine. Don't worry about it. All right. Let's play subjective objective again. You guys are going to be so sick of this. Patient skin is pale and dusky.
Objective.
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 And what are y'all doing if skin is pale and dusky?
Assessment.
What kind of assessment?
Focused.
Woo! I love that. Perfect. Y'all so smart. It's gonna go so good tomorrow. All right, cool. What if I say, I've been depressed for about 6 months now.
Subjective.
Subjective. Subjective.
All right, cool. Let's see. This is Dr. M. Patient has a history of depression for the last 6 months.
Objective.
Perfect. Now let's talk about the different phases of an interview during an assessment. Tell me what an introductory phase means.
Would it be when you go in and introduce yourself to the patient?
Guys, I'm telling you, nursing's common sense. Just make it simple. Don't overcomplicate it. Perfect. I love that for you. Tell me what summary phase is.
Education. Like giving education on, like for an example, getting discharged from the hospital and you're on new medication.
Okay.
Something to no? Okay.
No. You're fine. You're fine. So this is a part of an assessment. So in an assessment, this is usually the beginnings of throws and blows. They're not discharged. So that was the only caveat about what you said. But what you said was pretty relevant. So if I were to make a statement as a patient, a summary statement is going to be a summation of what they said. So what I would use as an example as a summary phase of an interview was, I just interviewed you because you answered a question for me. And what I understood is that you thought the patient was discharged, or you were given an example of a discharged patient, and you were explaining what a summary phase was. Is that accurate? Ish. Because that was an example of a summary phase of an interview. Does that make sense? I'm literally just exclaiming what you've said. So, or proclaiming what you just said. So if I say, hey, listen, I have a rash on my foot and it's been there for a week, I'll be like, all right, cool. So I understand you have a rash on your foot and it's been there for a week. Make sense? All right. What
Yes.
other types of phases are there? Anyone, can you think of any other phases?
Symptom analysis.
Tell me what that is.
So basically asking what if they're saying they're having pain in their arms, so you would say what relieves the pain that you're having.
I like that. I like all those answers. Perfect. Now, let's talk about victims of physical abuse, because this is a big problem. What do we have to be really, really careful about with victims of physical abuse?
You have to make sure you tell them what you're about to do.
Yeah. I love that for you. I really do. All right.
They
So we
have
have
to
to let
be
them know.
comfortable.
Make
You
them
have to make them comfortable and let them know they're safe.
Yeah. So if we see a bruise on somebody, how would we approach that? That it's an irregular bruise. I can clearly see it's a handprint. So like, how do I address that situation?
Explain that you've seen it before and ask them if that's something that they've ever experienced, and then listen.
Okay. All right. Do we ever assume that it's coming from a partner?
No.
No.
Do we ever assume that this bruise is a result of being abused?
I feel like we shouldn't use the word abuse. Is that right?
Nah, not really. Because honestly, there are indications where people would bruise. Remember, who are types of people that bruise very easily, right? Name one person. A
You.
hemophiliac, right?
You.
So if I were play fighting and I accidentally took an aspirin or Excedrin that day, right? And we were just wrestling around for whatever dumb reason, I'm going to have that handprint on me, right? Completely different indicator. Does that make sense? So you can't always assume that just because somebody is bruised and it is a handprint or it is a this or that, right? We have to look for other signs. So tell me, what are other signs of victims of abuse or victims of someone who's been human trafficked? What does that look like? Very important that we learn these nuances because it's very specific, right? And I need for you to be able to have a sharp eye with these things.
They're
Could they be
looking for
like
evidence.
Woo! I love how serious that was for my friends, because y'all just rattled off so quick, so many answers that I physically could not hear one of them. All right. That was beautiful. And I almost am brought to tears because I know what that means for me, and you guys do too. And we're going to leave it at that. I'm so proud of you guys. I'm so proud. Like, that made me so happy. Okay. So now that I have teared up because there's something in my eye, I swear. What does that look like for you guys? Tell me about those little reflectors that we see that go, oh, red flag.
Like timid.
Timid. All right. All right. What else do I have problems with? What can I remember and I magically can't produce?
The lack of eye contact.
Thank you. What
They
else?
don't know their address.
They don't know their address. Do they have an ID, guys?
No.
No, they had
No.
their IDs taken away from them. They burn them, they rip them up. They don't allow them to get another identifier. Once you can't get identification, it takes an act of Congress to get anyone to legitimize you, right? And if you don't have money, you can't get a birth certificate. Like it's part of the game. It's sad. All right, what else about this person? So again, who's talking to this person? Who's in the room with this person 9 times out of 10?
The person, what they call it, the John.
Well, they call it the John. Sometimes they call it mom. Sometimes they call it dad. Sometimes they call it boyfriend, whatever the deal is.
The person
Call it
controlling.
girlfriend, partner, whatever. Sometimes they call it captor. You have no idea, right? So we immediately need to get that person, whoever that is, out of the room, completely out of the room. And then we need to go back and double check on our person as well, our patient, to make sure that they're okay. Are you safe? That's where I scratch the surface because I want to know all kinds of stuff. And if that guy gets weird, what am I going to think about that? Guy, girl, person. I always say guy because that's a stereotype, but that's actually not as factual as you believe. Believe it or not, women are picking up the pace with being those type of people. So what do we need to look at these guys and say when we start to see them acting that way? We need to be super suspicious of that, right? If somebody's trying to argue with me so hard and you just can't seem to think of any facts that I'm giving you, then that's a direct reflection of somebody being super nervous because they can't be trusted, right? So just keep those things in mind. I think we hit all the big ones. Like I said again, I'm incredibly proud that you guys just pulled that off. That was amazing to me. So thank you. Let's see where are we at in the world now. Again, to clarify, to make sure that we understand what a patient is saying. If somebody says, I really don't eat that much often, and I go, all right, cool. How many calories do you eat a day? And they go, 200 calories a day. How am I going to question that without being overbearing and acting like I don't believe them, but also making sure because we're genuinely concerned of 200 calories a day? How do we go about that?
Going back with a number then?
Yeah. Did I understand you only eat 200 calories a day? Did I get that right? Yeah, all those things are absolutely acceptable so that we can clarify because that's pretty crazy, right? If it doesn't make any sense, there's no sense to be had. Just like anything else in this world, right?
I'm sorry.
Yeah, go ahead.
Can we ask them what their meal was like? Like, what did they have before? Would that be like an appropriate question?
So I would start with, did you say you eat 200 calories a day? Because asking them what they eat in a day is going to be my follow-up question with that. But right now I just need to clarify that they didn't make a simple mistake. Does that make sense?
Yes, thank you.
No problem. Good question.
Could you ask them like, is there a reason why you eat that amount? Like,
I would ask all those questions after I clarified if that's the right number or not.
oh, okay.
Otherwise, what we run into the problem of is a lot of times we just get a miscommunication. Maybe I don't hear them exactly as well as I wanted to. Maybe monitors going off or whatever. And then I've spent so much time asking them questions and they're like answering me to be polite, but they have no idea what I'm doing. And I've wasted 5 minutes. And it turns out that wasn't even the deal. It was my mistake. Does that make sense? Have you guys noticed I always say, does that make sense? Because I always want to clarify. I'm just so used to doing it. Does that make sense is going to be every phrase that is on every nurse that you ever meet after a sentence, because we're just so used to saying it to make sure that you understand. So again, I would get the clarifier first and then do all the follow-ups because those are always imperative questions that you just gave. Give me an open-ended question if somebody says they've been feeling really depressed lately.
Tell me more.
What was that?
Ask the patient to explain more or tell me what that looks
Tell me
like.
more about that because it might not be depression. If I validate that word depression, right, then it's somehow I've solidified that in their brain, right? So I don't want to do that. What I want to do is just say, tell me more about that, because it might not be depression. It might be anxiety. It might be agoraphobia, right? It might be, you know, something that they need a resource for. Maybe I find out that they're depressed because they've been drinking a lot of alcohol because their mom just died, right? And they don't have any like coping mechanisms. So I need to go get them resources that are outpatient, you know, things of that nature. So we're focusing out of the depression, and we're just trying to get them to elaborate on what that looks like for them so that we can establish what that means from a medicine perspective, from a diagnosis perspective. Does that make sense? So they could very well be depressed, but it might not be the depression that is a clinical depression. Does that make sense? So you just always got to check.
Like a situational depression.
Yeah. So tell me more about that is fantastic, because tell me more about that could mean anything. They might go into, you know, tell me about mom, or they might go into, you know, what's led up to this. Either way, I'm getting information about this person. The more I focus on that information, the more I learn about them, the more I know how to deal with them, right? So let's see. If someone gives me a weird symptom that's happened for a long time. All right, here's one. I've been having this weird rib pain over here, really high up after I eat for like the last 2 weeks. What is the next thing that I'm going to ask this person? More than likely. Am I going to say, why'd you wait so long to address this?
No.
No, I'm not going to go on them. So then what am I going to ask them to get more information to see what I'm ruling out as far as diagnosis is concerned?
What were you doing when it started?
I like that. What were you doing when it started? Or when it started? That's good. That's good.
Is your pain
Is it
constant or
continuous?
several?
Yeah. I heard something about pain. What was the other one?
Is it a continuous pain? Is it intermittent?
We're doing old card at this point. I love all of those things. Good. How about what other symptoms have you noticed? Right? If I have a constant pain up here, right, in my abdomen right after I eat, it could very well be gallbladder, but what else could it be? Well, it could be a lot of things. It could be
Yes.
an issue with like it could be a hiatal hernia from a little outpouching of your diaphragm. It could be a broken rib because you're a boxer, right? It could be a lot of things. So what other symptoms have you noticed is going to get me narrowed down? If they tell me that 30 minutes after they eat a cheeseburger, they had this crazy pain, I know it's probably gallbladder, right? Because they just ate fat. And that's what it does. So I know that that's probably my area of area of symptom more than anything. So again, rule out game. Good. All right. More importantly than anything, when you document something on a health assessment, it above everything has to be, come on.
Accurate.
Accurate.
Yes. So proud. Okay. Good. Okay. Tell me about elderly patients and what we need to consider with elderly patients.
It
They
takes
might have
them long to respond.
Alzheimer's.
Wow, you guys really studied well. Okay, one at a time. And now you're also polite. You don't want to start.
Takes them longer to respond.
Love that. Perfect. What else?
They might have Alzheimer's or dementia.
Is that normal for elderly patients? Dead silence.
It's
Is it
common.
Hold on, let me ask you a weird question. Is it normal in the aging process with the elderly patient for them to have memory loss?
Yes.
Yes.
Is it short term or long term?
More
Short.
so short term.
How you gonna ask me with a
It
question?
depends on the person.
Question. Shorts. Yes, it is short term. Good job. All right. It's little tiny things that are stupid, but it is not normal in the aging process for an elderly patient to be very forgetful. Okay. Don't get it twisted. Like, I forgot what tea I had this morning. versus I forgot to put on my shorts this morning. Like, big difference. Big difference. All right, cool. Let's talk about comfortability with patients. So if I see a patient who has a problem with their weight, not me, they have a problem with their weight, and I tell them, hey, can you come on the scale? Because I'm going to check your weight. And it's kind of like in like a waiting area. And I can tell that this person is just kind of looking at me and looking at the scale and looking at all the other people around. What would be the smartest thing for me to do as a nurse, please? Somebody tell me.
Move them to a private room,
Oh my
private
God,
area.
thank you so much. Perfect. What if they're shaking and they got goosebumps on their arms and they're kind of like this, right? What do I do?
Get a blanket.
Oh my God. Or turn the daggone temperature up in the room, right? Turn the temp up. It's that simple. Make these guys feel comfortable because they're going to give you better results and better outcomes and better answers during that time frame. I mean, I feel like this is simple, stupid stuff, but the fact of the matter is it's not. Common sense, unfortunately, isn't very common anymore. So now we teach you. But again, sometimes don't be offended with some of these questions that you get because some of them are pretty silly. But again, remember, this is about the bottom line nurse in Ohio. And the bottom line nurse changed a little bit when COVID happened. So we're starting to kind of rethink the way we understand nursing. So just take it and enjoy the free points. How about that? Tell me about patients. Are any two patients alike?
No.
No.
What if
No.
they're both? What if they're both at the same church, or in they both practice at the same place? Are they the same patient?
Doesn't matter. No.
But all religious beliefs and their like individual sects, they're all the same, right?
No.
So you mean to tell me that two people with identical religions have two different perspectives on the same religion?
Yes.
Okay, cool. I like that idea because it's absolutely accurate. There's going to be a split and divide somewhere. So, should we treat people from a certain spectrum like the next one over here?
No.
No.
Okay, cool. I'm being ridiculous for a reason. All right, go with me. So now that we've understood that people, regardless of culture, should be treated as individuals because we're still screaming the same stuff literally thousands of years later, and still nobody has gotten it. I don't know why. I can't figure these things out. It's like I'm on crazy pills some days. So tell me how that is close in reference to the concept of pain tolerance.
Everybody's pain level or tolerance is different.
Oh my God, that's such an abstract question I asked you, and it should have turned you all in a loop, and you just hit it hard. You just knocked it out of the park, friend. Good job. Who was that? I can't see who it is.
Markeisha.
Yes. With the win and the assist. Good job. Cool. Proud, proud. All right. We are nearly done, guys, I promise. As someone who has autism spectrum, I struggle with both verbal and nonverbal communication. Tell me what verbal communication is versus nonverbal communication.
Verbal communication is what you say, and nonverbal communication might be like your facial expressions or your hands.
Correct. Now, the good thing about having someone like me as your teacher is I'm completely inappropriate with my reaction because, a lot of times I don't react at all. That's beautiful because your patients are going to do the same because they're in pain, because they're scared, because they're sad. So believe it or not, you guys are going to get used to your patient population who is in a state of disarray every day when you come see me, right? So as nurses, we all struggle with being desensitized. And through that desensitization, we need to check both verbal and nonverbal cues, correct?
Yeah.
Correct.
Okay.
Yes.
So, as a patient who is seeing you as a representative of medicine, what do we need to do regarding verbal and nonverbal communication for our patient? I know I'm asking the same question I just stated. Just answer me. Just, I'm doing this for a reason, I swear.
Keep it in check.
Keep it in check. Keep both of them in check. And what is that going to show the patient?
That you're safe.
That you're safe and that you're expressing interest in what they're saying. And what is that going to ultimately give us? Better
Communication.
and health outcomes. I need for you, and you could have said a million of things that would have all been accurate, but I need for you to focus on better health outcomes come from expressing attention, expressing genuine interest in a patient using verbal and nonverbal communication. Is it easy? Not all the time. Sometimes you're exhausted and you're over it and you know they're lying to you, but you know what? That's just their moment, right? And in 5 minutes, it might not be the same. So just keep on moving and hope, just hang out with it. All right, now we're going to play the game of open-ended versus closed-ended questions, okay? So how about, what's your blood sugar on any given day?
Close-ended.
Love it. Perfect. Yeah, because I'm just going to get a number. What does the pain feel like?
Open.
Open.
Closed.
Love it. Love it.
Closed.
Open. What does the pain feel like? You could say it hurts. You could. I'll give you that. And that was actually my argument, is I didn't like that one at all. I do remember that now. You're right. What does the pain feel like is not my favorite question in the world, but truly it is both open and closed-ended. Okay. Well, that's going to be problematic, right? I'm going to officially call this one open-ended. All right. And here's my argument for that. And I'm going to settle it right here and right now. I'm going to call this open-ended because what does the pain feel like could mean anything from it hurts because you want to be ignorant and aggravating, or you could say it's sharp or it's dull or it's aggravating or any of those things as well. So for that reason, we're going to call it open-ended. Everyone got that? I struggle with that one. I don't like that one at all. I really don't like it. Does anybody else like that one? I kind of feel like it could go either way.
Yeah, it can, but then you just have to hit them with a rebuttal, like, so it's sharp, but is it like stabbing? Is it radiating down your leg? Blah, blah, blah.
Mhm. I agree with that. However, we're going to go ahead and call it open-ended and be done with it. How about, do you have someone to help you at home with your insulin requirements?
Closed.
Close.
Closed. What helps you learn better about your medications?
Open.
Open.
What typically helps you sleep better at night, and what is your sleep regimen?
Open.
Open.
Open, love it. Are you in pain all the time?
Close.
Close for sure. What methods have you tried to reduce your pain?
Open.
Open.
Open, good. All right, cool. We got this. Tell me about therapeutic communication. What is therapeutic communication?
Those open-ended questions.
I love that for you. I love that. So, here's one. Therapeutic communication is also an extension of complimenting your patient so that you can get an anticipatory answer. Let me explain. So therapeutic communication is communicating to the patient what it is I need to let them know. All right. I can ask them questions and be completely non-communicative and be very confusing for them. Case in point. Hey, I need to let you know that your ASTs and your ALTs were elevated. Also, you have a CVA and a potential MI. Is that therapeutic communication?
It's confusing.
Hi. What the heck is an AST and an ALT? I know. You guys would probably struggle with that. So we have to let them know, hey, listen, these are your liver enzymes. This is specifically this and this. Your CVA is cerebrovascular accident, or what they call a stroke. An MI is a myocardial infarct or a heart attack, right? So that is not therapeutic communication. You know what? You really just need to go ahead and listen to what I say and also what the doctor says. Is that therapeutic?
No,
No.
that's more irritating than anything.
Thank you. I love that for you. That's more irritating than anything. I'm irritated just by saying it. Perfect. When was your last flu shot? Therapeutic, non-therapeutic?
Non-therapeutic.
Why is it non-therapeutic?
Because how do you know that they get the flu shot every year?
Well, I'm
Like,
asking, when did you get your last flu shot?
well, I mean, like, it's just
Ooh, are you saying
very,
lying? Yeah, quit being too sensitive.
yeah.
No, I'm literally asking a question. I'm literally asking a question. And do you understand what it is that I'm asking you? That I've communicated therapeutically. See, therapeutic communication is the ability to let your patient know what it is you're trying to achieve or what information you're trying to get from them, right? It's not being presumptive, okay? Presumptive communication would be, making a side comment like, you're supposed to be getting your flu shot every year. Is that therapeutic communication? No, because you're being a jerk.
No.
Basically, therapeutic communication boils down to, are you being appropriate with them? Are you collecting the information without making it so confusing for them? Okay. Because we can wrap off a whole bunch of medical stuff, but if they don't understand what it is we're saying, they're not going to be any better off. They're going to be worse, if anything, and they're not going to trust us. All right. Now, let's jump over into the realm of biographical data, past health history data, things of that nature, okay? So if I tell you that I am 92 years old and I'm a female, what kind of data is that?
Biography.
Biographical.
Very good, very good. If I tell you that my mother had cancer 15 years ago, what kind of data is that?
Family history.
Very nice. I love that for you. Yeah. What if I say I had a thymectomy in 2020?
Past health history.
Past health history. Very good. All right, you guys got this one. I'm done. I'm not going to mess with that. Now let's talk about scenarios and having just basic wherewithal. All right, so here's the scenario. I am down the hallway and I see a patient who is crying and is pacing back and forth. All right. What would be my next step in relation to this patient who's in the hallway at random, crying and pacing back and forth?
Pain assessment.
I love that for you. I love that for you. Perfect. I mean, wow, you nail head, you hit it. Perfect. All right, cool. If I have that same patient and I know that I have to do an assessment on that patient, and they've had their pain meds and they're trying to settle down. And I need to go in there to assess something that's kind of silly. Like I need to talk to them about some kind of education and I can tell they're in pain. Do I go in there and start rattling off at them? What do I do?
Assess their
That's on their pain scale.
Administer
So,
medication
Let
according
me
to
make
this.
this clear. I'm a different type of nurse. So listen, there's many nurses that come into a patient's room, right? So I'm not the assigned nurse. I am another nurse who is doing extended education. Perhaps I'm a diabetes educated nurse. Does that make sense? So like that's not my patient. That's just a patient I'm referred to.
Come back again.
Coming in as a secondary nurse and I see that this patient right here that I'm assigned to is in pain, but I need to do an assessment on their diabetes. So what would I do as a secondary nurse when I see that patient in pain?
You come back later.
I come back later. I leave him be. Okay. I know it's annoying that you have to wait. I don't care, wait, because you're not going to get the right answer anyways with this guy if he's in pain and grimacing and doing all these things and crying. He's not going to be flipped onto the script. He's not going to listen. Okay. All right, cool. Tell me about elderly patients with severe hearing impairments. How do we have to change the way we do things?
I'm sorry, could you repeat that?
Of course. How do we deal with severe elderly patients who have severe hearing loss? I didn't put that part in there, did I? Whoops. All right, so I have an elderly patient who has severe hearing loss. How do I accommodate this patient? What's my procedure?
Talk slow.
Slow. Okay, good. I like that for you.
Go on the patient's side that they need to hear on.
Hey, I like that. All right, cool. Cool. What else?
Speak clearly.
Speak clearly. Yeah, for sure. Do I speak in a high pitch or do I speak in a lower pitch?
Lower.
Lower pitch.
Lower pitch, yeah, because the high pitch, the high frequency, they have trouble with. Very good. All right, where do I conduct my interview? Like, where do I talk to them?
Directly in front of them.
Quiet, secluded, private area. Turn off the TVs. Stop with the background noises. Okay. And do I speak soft? Do I speak loud?
Soft.
Yeah. Do I enunciate my words as best as I can?
Yes. Sometimes they might want to read your lips.
Sure. Yeah, most of the time they do. Absolutely. What is the one thing I do not want to do that people do all the time because they don't think about it?
Shout.
They shout and sometimes they turn their head away and you're like, oh, but I can't. Okay, I'll just wait until you come back. All right. So good. You guys got that. Let me give you a scenario and you tell me what the nurse did wrong. Ready? Sally, who sells seashells by the seashore, walks into the room and the patient is eating. And the patient goes, hey, can you check on my leg real quick? And then the nurse goes, yeah, cool. Because I'm Sally who sells seashells by the seashore. And then she goes and checks on the patient's leg. What does Sally do wrong?
Check on the patient's leg while she was eating.
That's gross enough, sure. But no, we got something worse going on.
Hand hygiene.
Oh my God, you didn't wash your hands and you're touching my leg. You're touching my wound potentially. I didn't say what was on the leg. It could have been anything. Gross. Very good job. All right. All right. How about this one? How about I do a head to toe assessment on my patient? And then I ask them if they need anything and they say, hey, I just want my soda. Could you put my straw in my soda? And I say, yeah, sure. And I put it in. And then I said, do you need anything else? And they said, no, I'm good. And I said, okay, have a good day. What'd I do wrong?
Like you weren't kind of inviting to let them know that they could ask for more, like additional help if they needed?
Okay. Okay. That is an accurate statement. What did I do that was going to be really gross though?
Oh, you didn't wash your hands on the way
Oh my
out.
God, no, I did not. I totally messed with all kinds of things and then I just walked out of the door for the next one to have. Yuck. Okay, perfect. I love that for you guys. You think I'm joking. This happens all the time, friends. All right. Let's talk about PPE, protective equipment. Okay. We're going to talk about isolation types. Tell me what standard precautions are.
I'm sorry, repeat that again.
Yeah. Tell me what standard precautions look like. What do you have for standard precautions? What are they?
Gloves, mask, and gloves.
Mask.
What is standard precautions?
Hand washing.
Gloves. Hand hygiene.
Just hand hygiene?
You said for isolation, correct?
Standard precautions. PPE and standard precautions. What is a standard precaution?
Gloves.
Wearing gloves.
Cool. And washing your nasty hands. Cool. All right. If I have explosive watery diarrhea, what condition do I have more than likely?
C. diff.
C. diff.
What's precaution for C. diff?
Gloves, gown,
Full
wash your hands with soap
PPE.
and water.
It's not
It's
full
like-
PPE because what's full PPE?
You don't have to wear a mask. It's just gloves and gown.
Gown, mask, goggles,
Oh, okay.
gloves is full PPE. I know what you're going to say, and you are accurate, but in the nursing world, as far as baby nurses are concerned who never have any medical experience, what you're about to say is completely accurate. I would wear a mask. Been there, done that, got the t-shirt. It's size medium. I'm just saying. In the world of C. diff, technically it's gown, face shield, gloves, but I would definitely wear a mask. Absolutely. Oh, incidentally, what's the only thing that kills C. diff?
Bleach.
Oh my gosh, thank you. What's the bleach time dry out? What's the dry out time for bleach?
Is it a full minute?
It's more than a minute. It's like 90 seconds to 5 minutes even. But more importantly, if you don't know the answer, it's on the back of the container. Whenever regulatory compliance comes in, they're always going to ask you that question, and you actually have a freebie. You're allowed to say, I don't know the answer, but I'll go find someone that does. That's not on your exam. I'm just helping you. All right. Tell me an example of inspection. The assessment process of inspection.
Looking at
Like
skin.
looking at the body.
Visible.
I love that. What about counting respiration rates? What about checking for cognitive delays? All of those are done by inspection. Very good. Tell me about palpation.
Light touch.
Light touch. Give me an example.
Check in your forehead for fever.
Yes. Oh, heavens me. Perfect. Love it for you. What else can we do for palpation, this light palpation? Can I check
Would
for
it be
Abdominal.
radial?
what is it? What'd you say?
Radial.
Dang, did you just say radial check? Did you just literally? Oh man, are you in my lab? You're in my lab, aren't you? I can't hear.
I was in your lab yesterday.
Yeah. I can't tell who's talking, but I'm like, dang, they just broke out the radio. It's red, dude. That's how you check the radio. You go, it's red, dude. I'm gonna go down the ski slope right over here, and then wherever he drops is where your pulse is. That's how you check it. Some people don't know where it's at. I've always done that. All right, cool. So feeling the temperature of your skin, doing edema checks, right? This is all those things. Tell me about percussion. What is it? Oh Lord. Y'all try to define percussion.
Is that kind of more invasive? So like when you checked like the tummy, right?
Yeah. So it's tapping, right? Remember, think two words. Think TT, tapping and timpani. Tapping and timpani. Right? This is more about a rhythmic drum sound that is going to have either a deeper resonance or a very tight resonance, right? So if it's a hollow and it's got air behind the sound, what is that an example of? Is that a hollow organ or is that a dense organ?
Hollow organ.
Hollow organ. Give me an example of a hollow organ.
Was it the liver?
No, the liver is not a hollow organ. The liver is a very dense organ because it's very heavy. Also, it doesn't have like air in it, but what does?
Lungs.
Okay, I'll take that. What's a better one that I can actually do timpani on and percussion?
The kidneys.
How about let's try something that's got like light and airy.
Like the naval cassette,
maybe
naval
contract.
cassette.
Stomach?
Yes, stomach, absolutely. Yeah. Stomach was what I was looking for. Intestines is cool too. We can play that game, right? Anything that's going to have a change in resonance. Now, what are the dense sounds? The dense sounds, okay, listen, This is a light and airy sound. Listen. You hear that? Now, here's a dense sound. Hear the difference? All right. A dense sound tells me I got what there? Is that a hollow organ, dense organ? Big organ?
Dense organ.
Yeah, for sure, dense organ. So the higher the sound, the less tympany that you have, you know, you're going to be walking over a really hard organ. That's what you need to understand with the tube. I know that sounds silly, but a lot of people have trouble understanding that, and it is important material. Now, let's play the game of I'm doing an axillary temperature. All right. If I get an axillary temperature of 100.2, what would my oral temperature be?
101.2.
Does everybody?
99.2.
So, whoa, we're getting different numbers. All right, let's do this again. I have a temperature of 99.6. Okay, I took it in my axilla. What is my oral temperature?
100.6.
Beautiful. Beautiful. And it's because your mouth has, well, your internal up under your tongue is kind of a nice internal space versus my armpit. If I keep it open for too long and then I close it, it's gonna have air around it, right? So it's potentiates being a little bit lower. All right. Tell me a normal respiratory rate.
16.
16.
What's the range?
16.
14 to
Was it
20.
12 to 20.
I thought it was 12, 20.
It's 12 to 22. 22, when we get into 22, is the danger. We normally say 12 to 20 just to be honest and even. 22 is when we start getting in the hot zone. So let's just say 12 to 20 and be done. Okay. Does that make sense? 12 to 20, be done. So if it's under it or over it, we're in danger zones. But usually, honestly, it's in most hospitals, it's 12 to 22. But in your book, it's going to be 12 to 20. So keep 12 to 20. All right. Give me a normal blood pressure, like a regular range blood pressure.
Under 120.
Under 120 is half of the answer. Okay. Where is our hot zone?
Under 120, under 80.
120 over 80 is our systolic and diastolic pressure. Yes. When I say hot zone, when do we get into dangerous territory? Because it's not anything other than 120. Because if it's 78, that's a bad day. When does our hot zone start?
140.
Going down.
Anything of 80.
For
like,
systolic? Okay, so let me help you out.
Oh, okay. You meant like systolic?
Yeah.
Anything over like, well, I don't know. I think it really just depends on person to person.
That is an accurate statement, but from a textbook perspective, the answer is anything over 100. So from 100 to 120 is usually okay, right? When we get into the 99, that's when we start making it a hot zone. It's like the difference between 60 and 59 on the heart rate. Okay. So 60 to 100 is the heart rate. And then saturation, we usually like to keep it 92 or above, unless you have like a condition like COPD, in which case we're going to hang it a little bit lower. I say all these things because you might get into a situation where you have to clarify which is considered appropriate and which is considered not with vital signs. All right. How would we rate a patient's pain?
Ask them.
According to what they said.
We have to rate their pain as they're experiencing it. Do we have to take it as face value?
Yes.
Yes.
Absolutely. Absolutely. Because remember, what differentiates my idea of a 6 versus your idea of a 6 on a 0 to 10 scale?
Pain tolerance.
Pain tolerance, right? Because patients, they may not have the same objective responses to pain, specifically to chronic pain. Because remember, with chronic pain, you compensate over time. All right. So with that being said, what's worse for a patient? Chronic pain or acute pain?
Chronic.
Acute pain.
Chronic.
Right. Listen, if I have chronic pain, my body is used to that pain, so it desensitizes itself, right? Remember
Right.
remember the first time you had an animal that passed away? Remember how devastating it was? Remember the second and third and fourth time, or however many times you've had an animal pass away? It still hurts. Does it get a little bit more acceptable? Like, okay, I get it, right? It does, because you become desensitized to it. It's the same concept with chronic pain. Now, if I openly, have another condition that comes out of nowhere, that pain is going to be far more severe because I've not gotten used to it. So we're going to look at acute pain as something that is going to affect a person who has a chronic condition far greater than if they did not. Did that make sense?
Yes.
Maybe so. Okay. Like people have bad backs. That's a chronic pain. But if I go and break my leg, that broken leg is going to hurt 10 times more. Or if I stub my toe, that stub toe is going to hurt 10 times more because I'm used to my back hurting. All right. Let me give you some Latin. Card.
Heart.
Heart.
Heart. Love it. Neuro.
Brain.
Nephro.
Kidney.
Okay. Hemato.
Blood.
Liver.
Blood. Hemato, or hold on, wait. Yeah, hemat.
Hey, where you going?
Hemat versus hemato. I'm teaching. What you doing? All right. So hemat is blood for hematology. Very good. How about hepa? Hepato.
Liver.
Liver.
Yeah, you were hearing Pat, but I was saying Matt. Perfect though. If I say I have if I say I have gastritis, what is the surname? Like what is the suffix of that?
Itis.
Itis.
What does itis mean?
Inflammation.
Yes.
Inflammations.
Inflammation is itis. ITIS. I love it. All right. So let's play the game of anterior versus posterior. All right. The nose, nope. Yeah, okay. The nose is blank to the ears.
Interior.
The nose is interior to the ears. Perfect. All right. Everybody get that? So if I were to say, let's use anterior, posterior, superior, or lateral. Let's do, let's do the ears are blank to the temple.
Superior.
If your ears
Posterior.
are above your temple, then they're on top of your head, like a mini map.
Lateral.
They are lateral. Good job. I'll take that as an answer. That's cool. That's cool. All right. I think we got that right. So anterior, posterior, superior, lateral. What would this be? If this is superior and everything's on a mirror image, energy, frequency, vibration, and balance, what would this be?
Inferior.
I love that for you. And that's good. This would also be called supra, like superhero is going up in the air, versus sub, which is like a submarine that's going down into the ocean. Yep. All right, cool. Let's play distal proximal. Ready? The wrist is blank to the index finger.
Distal.
The wrist is distal to the finger. Remember, whatever we say is proximal is closest to the patient. So it's asking you which one of these is closer to the patient, the finger or the wrist?
The wrist.
Yeah, the wrist. So the wrist is proximal and the finger is distal. Do you got that? Did that help?
Yes.
Yeah.
Everybody good? So let's do one more. The elbow is blank to the shoulder.
Distal.
I love that. Good job. Okay. Tell me what it means to lay on your back. What's the technical term for it?
Supine.
I love that. And if I were on my belly?
Prone.
I heard prone. That's beautiful. Tell me what high Fowler's is.
You're sitting up at an angle.
Straight up at attention. And I just pulled my cord out. That's beautiful. So you're sitting straight up at attention. I love that for you guys. Perfect. Okay. Now let's play the game of math. This one's going to be super difficult. That's sarcasm. All right. You ready to write a number down? I want you to write down 4.68. And I want you to round it to the nearest tenth. And what do you get?
4.70.
What about the zero? What did I tell you about the zero? If you put a zero in tomorrow, even though a zero belongs there mathematically, what do nurses do? They count it wrong. Do not put a zero at the end. Leave it at 4.7 and be done. Does that make sense?
Thank you.
I say that it will count you wrong. And if it does count you wrong, I cannot change it. This is why I'm begging you to not put a zero at the end. Okay. But you're absolutely right. But mathematically you are. In a nurse's world, it doesn't matter. Trust me, I had to get clarification on it. That's why I absolutely want to tell you that. I don't want you missing a point for that. All right, do another one. Let's do 11.83 to the nearest whole number.
12.
Love it. Questions on that? All right, let's play another game. Let's play the game of I have 90 tablets and I drop a third of them. How many more do I have left?
60.
Everybody agree? The answer is right.
Yes.
Good job. All right, here's the problem. Sometimes we're going to ask you about tablets remaining. Sometimes we're going to ask how many were dropped. You have to pay attention. All right. Keep those in mind because it might ask you either way. So a lot of people make simple mistakes and that causes a lot of points. All right. Now let's talk about tuberculosis patients because I forgot to ask about tuberculosis patients regarding PPE. What does PPE gear look like for tuberculosis patients?
N95 or a well respirator.
Tuberculosis patients are going to be completely different. We are going to put them in, you're in a HEPA respirator. A HEPA respirator is a ghillie suit. All right. It is a respirator over the nose and the mouth. And theoretically, it's an entire hazmat suit, if you will. Right. That would be the ideal. So you wash your hands, you place on your HEPA like respirator, and then you ghillie in and zip in. Theoretically. Now, is that the perfect world? No. But in this case, we're going to play perfect world because we're going to pretend we have everything in the world. Got it? Tell me about, let's go back to abuse. Tell me about what puts a person at a very, very, very increased risk for abuse. Think about dependence on people.
Peasants with suicide.
I'm sorry, what?
Peasants with suicide.
One more time and say it slower. I'm sorry. What did you say? I missed it. All right. We need to just adjust the fact that we need to understand that when we're dealing with people of suspected abuse, it could be by any means, Usually, when we're talking about this kind of stuff, we're talking about very emotionally fragile people, or we're talking about people who are very elderly and ill. They are basically dependent on their family members for their food needs and for their medication needs. All right. It puts them at a very, very high risk. So, what do we need to do regarding their family member that they're living with to help with them being calm, to help with them being compliant, since they're truly the ones taking care of that patient? What do I need to make them a part of?
A part of the care plan. So
A part of the
explaining.
care plan. Yes. Beautiful. You have to make them part of the care plan, make them part of the discussion. If you don't, they're going to find it very offensive. It's going to go really bad really quick. Okay. If I have someone who is of a different culture, what is it that I need to ask that family member about that? And why do I need to ask it?
You need to ask the preference of how they would like to be cared for, and you ask this because you don't want to offend anyone.
Yeah, you need to ask those kind of questions because you don't want to do anything to be offensive to anybody. Guys, medicine, I'm telling you, medicine is 90% showing up and giving a darn. Honestly, I am a good nurse in medicine, not because I'm a genius, because trust me, I'm not. I'm only a genius because I made so many mistakes. So I know what to tell you not to do. The reason I'm such a good nurse is because I, believe it or not, can communicate with people very well. I don't do it with you guys because remember, we're in a sandbox environment. So I mess with you guys a lot because I'm trying to put you in line without making everything so micromanaged that you feel like I'm taking a piece of you away. So I do it kind of under the radar. We let you know when I'm doing it all, right? And you just sit there and think I'm a crazy person and I let it go because it doesn't matter. So when you're dealing with patients, you have to understand that most of what you're going to do is based off of just blatant communication. I could be the worst nurse in the world technically, but if my patients are on my side, I can do no wrong. Does that make sense? So ask questions, explain why you're asking questions. The last thing you want is to ask a question that might sound remotely ridiculous or remotely biased in any type of way, and then not explain why you're asking that. And then these people just assume that this is why you're doing what you're doing. That could go really bad really quick, right? All right. Now let's go to vital signs. If I have a STNA call me and they say, hey, real quick, I just took a blood pressure and it was 202 over 117. What are you going to tell that person to do, or what are you going to do yourself?
You're gonna go check it manually.
Cool. What arm am I going to check it in?
Opposite arm of the one that she
Oh my
checked.
God, you're so smart. Yes. Check the opposite arm for the love of Pete. Like if that arm just went that ridiculous and got that squeezed up, don't use the same one because it's just going to show up abnormally high. You're going to start a stroke alert for no reason. It's going to be a whole hoopla. Don't do it. It's silly. All right, let's play the game of percentages. And then we're about to be done for real, like in about 5 minutes. All right. If I consume 25% of my medication and I have 100 tablets, how many tablets do I have remaining?
75.
75.
Cool. If I consume 50% of my tablets, how many did I take?
50%.
50.
I know you guys think I'm stupid, but I'm actually doing this to you on purpose. If I consume 75% of my medication, how many did I eat?
75.
Okay, I'm done with you guys with this. Oh, here's one more. In this cup, I have 20 milligrams of powder medication, and I have it in 100 milliliters of solution. 20 milligrams of powder in this medication and 100 milliliters of solution. In this hand, I have 200 milliliters of solution How much powder do I have?
20 milligrams.
How
I
many-
think you said 20 before.
How many did I have over here? I had 20 and 100 over here. Right? So if I got 200 over here, then how much milligrams of powder do I have?
40.
Cool. Everybody get that? I'm literally just doubling it. That's it. So this is called ratio and proportion. Remember, medications that are mixed in a bag, like an IV piggyback, is both powder and liquid, and you mix them together. I know it sounds weird because you just see the Kool-Aid, you don't even think about it. But there's also a powder weight in milligrams, and then there is a liquid weight in milliliters that combine together to make the IV piggyback. So ratio and proportion requires for you to account for both of those things. I may ask you, in this cup of 25 milliliters, I have 50 milligrams of powder. Over here, I have 100 milligrams of powder. How many milliliters do I have?
50.
So I literally just reversed it. Did you see that? So again, ratio and proportion. All right, friends, here's the deal. Do we have any questions?
Not right now.
Okay. Tell me what ergonomics are really quick.
Your natural posture.
Very good. It has to do with normal body mechanics. I love that for you. Tell me what cyanosis is.
Glowing of the skin.
What does it mean?
Lack of
Lack
oxygen.
of oxygen.
All right, cool. Let me jump on real quick because I'm going to jump out of what I'm doing. And then I'm going to put on, well, my camera's already on. Guys, look at me, dead in the face. You guys are going to do phenomenal tomorrow. Got it? Everybody feeling it?
Thank you.
Yes,
Okay.
Yes.
Seriously.
very much.
A deep breath. You guys are doing a fantastic job. You guys have clearly paid attention to the review. You guys clearly know what's up. You're going to do great. If your biggest concern tomorrow is, oh my God, I can't get into ExamSoft. Cool. I will get you a temporary computer. We will take your exam. I need for you walking in there like a chill little pill. I don't need anyone ill. Okay, cool. You guys got it? Like, just take a deep breath. It's going to be okay. Cool.
Thank
Yeah.
you.
All right,
How
get your
many
to bed.
how
50
many questions are on the exam?
50 questions. Every exam you're going to take, with the exception of HESI's, are going to be 50 questions for the entire program, with the exception of HESI's. You guys got this, okay? I'm proud of you. I love you. You guys are smart. You guys are good enough. You guys are worthy. You guys are going to do great. You guys are going to
So
jump.
tomorrow is an exam, not a quiz, correct?
Huh?
So tomorrow is an exam, not a quiz, correct?
Oh yeah, we're doing a 10-question quiz tomorrow, which is why I spent 2 hours bugging you guys. No, tomorrow's an exam, sweetheart. We're not doing a quiz. We never do a quiz the week that we do an exam. Ever, never, never. You guys can start signing off. It doesn't bother me. I'm just literally saying on if you guys have any extra questions, you're good. We're definitely having an exam tomorrow.
Hi.
Bye. It's gonna be fine, guys. You're gonna do fine.
Thank you.
Thank you.